2 IMAs, a single-center 10-year study.
Good afternoon, dear colleagues. From the beginning of my off-pump career, I dedicated in a method in which we combine off-pump aorta non-touch total arterial revascularization. But next. Because all of them, innovations, is proven to favor the long-term outcomes. In our philosophy, we combine all of them, creating an arterial circuit which is connected to the diseased coronary bed without any aortic manipulation. In a part of our clinical practice, we apply the method using exclusively both internal mammary arteries, provided that all the peripheral targets had severe and similar stenosis. Our aim is to record and present our 10 years experience following this subgroup of patients for 2 to 12 years. From a total number of 3,200 cases applying the PGRAPH method, 1,077 were revascularized by the exclusive use of both skeletonized internal mammaries. Last follow-up was done in June 2013. 72 patients were out of analysis. We calculate cumulative survival and events rates using Kaplan-Meier estimates. These are the characteristics of the patients: age, sex, BMI, diabetes, hypertension, cholesterol, moderate impaired injection fraction, severely impaired, 10.5%, renal insufficiency on dialysis, peripheral vascular disease, prior stroke. And these are some pre-constructions in order to do this technique. We are using bifurcations or trifurcation, and we are doing sequential anastomosis as well. 2.8 peripheral anastomosis per patient, 19 patients needing intraoperative balloon pump ERBP preoperatively, 52.8% of patients had sequential anastomosis, 1.35 per patient. These are some arrangements. This is the cross arrangement, right mammary to the anterior wall, left mammary to the other wall. This is the long Y graft, the whole rima to lima, in order to do in a sequential way all distal anastomosis. 14 patients were reopened for postoperative bleeding, 3 patients less than 0.3% reopened for hemodynamic instability, less than 0.3% needed ERBP postoperatively. Some other arrangements not very usually used. This is the lambda graft. Half of the free rima is connected to lima as a T or Y graft, and the other half is to extend the lima to reach the RPD. And another arrangement, in some cases with very small targets, in order to increase the total runoff. For example, in diabetics, we use one IMA to bridge all these peripheral targets, and then we lead the flow of the other one to the bridge. 16 patients remained on mechanical ventilation over 48 hours. 1.6 had gastrointestinal complications. Less than 0.2% suffered CVA during hospitalization. Both patients had carotid disease. 0% had sternal wound complications. We include here even the minor complications. 19% atrial fibrillation postoperatively. Here are the results. perioperative 7-day mortality 0.3%, 30 days mortality 1.1%, all cause 10 years postoperative mortality 8%, total number of deaths 9.4%. The May ACC postoperative events were 116, 11.6%. All death 8%, cardiac death only 1.7%, stroke 1.2%, MI 0.9%, and repeat revascularization 3.4%. And if we will consider the fact that the mean postoperative time is almost 5 years, we could arbitrarily compare our results to Syntex to see how excellent the results are according to cardiac death, postoperative MI, CVA, and revascularization. And after all of them, I could say that total arterial vascularization with the use of both internal mammary arteries on off-pump beating heart surgery, aorta non-touch as well, is a feasible combination with excellent results when performed by experienced cardiac surgeons in off-pump surgery. Thank you very much.
Thank you very much. That was an excellent presentation. We've had a very large series today, 1,000 patients and above of coronary revascularization. Excellent presentations by all. We have a time for a couple of quick questions. I had a question for Dr. Moss. Could you describe the strategy once an epi-aortic echo in your study showed atherosclerosis? What would you do? And did you ever use anything other than heartstring in the non-clamp group?
Yeah, it's an excellent question. So, I mean, we don't necessarily have an algorithm that every surgeon uses. It might vary a little bit per surgeon. But in general, if there is concern on the epi-aortic ultrasound, we would tend to go with the heartstring, which is the only one that we're using presently at Emory. But again, you know, if a surgeon, probably earlier in their experience when we're probably using less heartstring, if there was an area of the aorta that was safe to clamp, you know, if the high-grade atherosclerosis was somewhat more proximal and a little more distal, there was an area to clamp, we probably would have. I think lately, once there's a higher grade atherosclerotic burden, surgeons would be more likely to use the heartstring. And as far as the clampless technique, it would be either the heartstring technique or a no-touch technique with using your pedicle grafts for inflow and then putting either a vein or radial off of one of the two mammaries that are being used.
Were there any passport proximal devices used?
In this group of patients, there was not.
Dr. Zapolansky.
Just going to throw a little monkey wrench into the whole picture. Okay, here we just spent the last 2-3 hours discussing how to make this operation better, whether off pump, on pump, little incision, big incision. We haven't discussed at all the intraoperative graft performance as an element to predict whether the patients are going to do better in the near or in the long range. And it's surprising, you know, and I take up on Dr. Prapa's comments that he said, well, we made sure that all the grafts were, all the native arteries were appropriately occluded or narrow, right? Because you didn't want to have a competitive flow. We haven't discussed this issue at all, and I think it's extremely important because not infrequently I am presented with cases in which cardiology read lesions as whatever, you know, 80%. You send them to do an FFR or an IVUS or whatever and say, oh, you know, by the way, this artery is not that tight. So we have two problems. We have a problem in the diagnostic tool that we're using to make decisions to operate, even though the results are pretty good overall. And then we have a situation in which we don't routinely assess grafts before the patients leave the operating room. Just throwing that out there because this introduces two new elements to the improvement of the coronary bypass operation.
So if I read your paper correctly, you check flow rates in all your graphs. You check flow rates in your graphs. That was
Initially, we checked the flow, but slowly we stopped doing that because of the costs, because we realized that the technique works.
I think you should be congratulated on taking the time to actually use bilateral mammaries and use them in some unique strategies that a lot of people don't take the time to think about ahead of time. And I think that really only 4% of patients in the United States get bilateral mammaries, and I think part of it is just people not taking the time to really think about it. I've said it earlier today, but there's clear survival advantage that's at 7 years by using bilateral mammaries. And I think that's what we really need to sell to the cardiology community and patients as a whole. You're going to live longer. That's, I think you've added to that body of work today. Thank you.
The most important is to do a different operation for each patient according to all of them. Dear colleague described before, if I have a moderately stenosed target, I have to put an isolated graft on it. I combine all the other targets only if the stenosis are severe. And of course, you have to be meticulous in order to prepare nice skeletonized mammaries. They have long, wide to cover all the needs. You have to do meticulous anastomosis, and if you will follow some guidelines, everything will be good.
Dr. Srivastava, last
just follow up on the same issue, Dr. Papas, is for you. In the right coronary, using right mammary, what are the pearls? When would you use and when would you not use?
This target is difficult because we consider stenosis, for example, 90% for a target which is 1.5 millimeters in width. In right coronary, the lumen is around 6 to 7 millimeters. 80% or 90% for this stenosis means a true lumen about almost the lumen of the other coronary targets. Therefore, I don't use the right mammary torch to RCA, never, because it's going to be atrophied. I consider the RPD in these reconstructions and arrangements only if I had an RPD with totally occlusion, 100%. In these cases, I lead the T-graft towards to RPD as the last target to be anastomosed.
Thank you very much to our speakers. I don't know if Dr.